Okay, welcome viewers. This is Sarah Merritt coming to you live with Livestream Health Center. Surprise, we're early for you live viewers, and for you replay viewers, give us a hashtag replay in the comments. I am excited to be with you tonight because we have a special guest, and I'm going to let her introduce herself.
Hi there, Dr. Merritt. Thank you so much for having me. I am Niña Carmela R. Tamayo. I'm an osteopathic physician and specialized in physical medicine and rehab and subspecialized in spinal cord injury.
Excellent. And I think we want to talk a little bit. So I just jumped right into this. You know, my practice is Livestream Health Center. I am an anesthesiologist and did a fellowship in pain management, and so this is what I do. Is at Livestream we try to provide the best in acute and chronic pain medicine and make it caring and accessible, patient centric, and evidence based.
Mhm.
Dr. Tamayo and I were just talking, and she has a background in physiatry, and I think it's important to understand that different doctors who do pain management, right? Like I might say, "Hey, I'm a pain management doctor." Dr. Tamayo might say, "I'm a pain management doctor," also, and we're more similar than different, I would say, and maybe
Yes.
you agree with that. I think, right? But
Hmm.
I think we do have like different lenses. We have our different little glasses on of
That's right.
how we look at things and think about like the same problems. And so I love to like explore a little bit of that and what might be the value of having a physiatrist on your team if you had a serious pain problem.
Yes. So I figured I would start first with the basics and,
Mhm.
kind of go through my training in particular and really starting off with a definition of what osteopathic medicine is. So
Mhm.
I'm a DO, and Dr. Merritt, you are an MD. And essentially, for DOs, we have a sort of a whole person approach to medicine. And it's really treating the entire person rather than just the symptoms. And we really focus on preventive healthcare. So in terms of our training, MDs and DOs go through the same requirements: 4 years of college, 4 years of medical school, and we can prescribe and are licensed in all 50 states.
Mhm.
And we can go into the same residencies and fellowships and subspecialties as well. I think the difference is that we get an additional 200 hours plus of extra training in musculoskeletal health,
Mhm.
and we
All
have
DOs, even if they don't go into
right,
physiatry
right.
or musculoskeletal. Yeah.
Yes, correct. And we have an extra tool in our toolbox called osteopathic manipulative treatment, or osteopathic manipulative medicine, where we basically use our hands to, diagnose and heal. And we have different techniques that we can provide
Mhm.
for patients, especially who are suffering from pain. So it's nice to have that as an additional tool, especially in clinic. And most of us, you can utilize it even in primary care. You don't have to be a subspecialty physician to utilize it. I think what's nice with my physiatry background is that being a DO really helped set me up for success to be a PM&R doctor, because we do get that extra MSK and neuro really training. So
Mhm.
it helped, again, kind of provide me an extra lens of seeing physiatry in a slightly different way.
Mhm.
And so, the other component about being a physiatrist is, for example, as a spinal cord injury specialist, we really look at everything, so we're basically primary care physicians for spinal cord injury
Mhm.
patients.
Yes.
And so, because as a DO, we have that sort of preventative lens, I can utilize that when I'm treating my patients. We have like a whole person approach, as I said. So we're also looking at socioeconomic issues, psychological issues, and so, with the osteopathic manipulative medicine, and specifically for treating for pain, it's
Mhm.
a really nice way to bring to our patients. We look at everything that could affect how they perceive pain, how they experience pain, and again, with the OMT, it allows me to treat them hands-on right in the clinic, and not just, give, narcotics or other pain medications. But it's a sort of a, it's a quick, I don't want to say it's quick, but it's something that I can do right in the office,
Mhm.
and they don't have to wait, for
Yeah.
their medications, and you can see fairly instantaneous relief from pain. So,
Yeah, that was what I was gonna
yeah.
ask, was sometimes the
Hmm.
results can be right away then, right?
Right.
That's
Hmm. Hmm.
that's what I've
Correct.
been told about.
Yes.
Awesome.
Mhm.
And so then so my background again is medical school in a traditional allopathic med school,
Mhm.
which is the med school that gives the MD degree. And then then there are both kinds of schools, as Dr. Tamayo said, that can kind of get you on the same path. I think that combo of DO and PM&R is actually really neat because it
Mhm.
kind of sets you up to have that musculoskeletal knowledge and then the physiatry residency, right? That training that you did
Mhm.
after med school
Right.
kind of goes deeper on that. Tell us about what is a physiatrist exactly?
Yeah, so I like to call us the function doctors. So it's PM&R, physical medicine rehab, also known as physiatry or
Mhm.
rehabilitation medicine. It's a branch of medicine that focuses on helping individuals with physical disabilities and injuries to restore their function, their mobility, their quality of life. And
Mhm.
so physiatrists are trained to treat a whole range of conditions. So that can be musculoskeletal, that can be neurological, cardiovascular as
Mhm.
well. Primarily, I consider myself a neurorehabilitation physiatrist. So I focus on stroke, spinal cord injuries, traumatic brain injuries. But other things that we also address are amputations, chronic pain,
Mhm.
arthritis, and sports injuries. So a lot of what we look at is, okay, so this individual has gone through either an accident or some kind of traumatic incident that has left them with a physical disability. Where a PM&R doctor comes in and addresses things is, so now we have sort of a new normal, right?
Mhm.
And so we provide recommendations in terms of how to uh, get them to as close to their baseline as possible. So we help provide recommendations for assistive devices, for example, or durable medical equipment, prosthetics and orthotics for our amputee patients. So
Mhm.
really focusing on that functional aspect of life and their activities of daily living and independent activities of daily living. How can we help through a multidisciplinary approach with our colleagues in physical therapy, occupational
Mhm.
therapy, and speech therapy, and social work to provide a comprehensive treatment plan for our patients. And we also work with, our orthopedic and neurologic,
Mhm.
colleagues. And so it's a really nice field to be in because we get to work as a team. There's really no I in rehab. I can't do my job without
Mhm.
my team of therapists and also my colleagues in other fields. So I think it's really nice to have that multidisciplinary approach.
Mhm.
And yeah, like I love the fact that I get to create relationships with my patients, and I really do see them get better. And albeit
Yeah.
maybe slightly different from how they imagined to get better, but
Yeah.
for us, it's so gratifying to see somebody um, be able to do the things that we take for granted. For example, getting dressed, even brushing your hair, putting your makeup on. I think, as able-bodied individuals, often take all that for granted, and so I get to see my patients, be able to achieve those what we call small things, but they're really milestones for us. So
Yeah.
something that they weren't able to do yesterday that they can do today, it's a win, and it's a big win for us.
And I'm
So
sure
it's very
celebrating
special.
that. Yeah,
Oh
yeah, and I'm
yeah,
sure
yeah,
celebrating that just has to really, be a special opportunity to have a bond and to, um,
yes.
be part of that journey.
Absolutely. Yeah. I was never a cheerleader but when I was younger, but I get a chance to be that now as an adult, and it's
Yeah.
great, you know. So my patients, I'm only 4'10". So,
Mm.
I have this 4'10" Asian lady coming into the room, like,
Yeah.
screaming out, "Yeah, you can
Enthusiastic.
dress today." And they're looking at me like, "You're nuts." But I think that has it really puts things in perspective for my patients too, that I'm celebrating something as simple as getting dressed or being able to eat. So
Yes.
it's really nice to kind of see their reaction, and then they start realizing, oh, I'm able to do something today that I didn't get to do yesterday, and they
Yes.
start to reframe, and that's part of the rehab process.
Oh my gosh, yeah, I think that is so big for really any patient that struggles with pain or with a diagnosis, right? Sometimes that reframing, and it's not to discount that there may have been a loss, but
Right.
how can we move forward? How can we get something positive out of it? And to me, it probably does involve um, celebrating
Yes.
the wins that you get.
Absolutely. And I think that I've I think now that I've been in this field for a few years, I've really had an issue with the word disability,
Oh,
because that's not how I see it,
oh,
Yeah, so I see a lot of my patients as just having different abilities,
yeah, differently
and
abled.
so right, and I think now that you'll
Yeah.
probably see a lot more highlighting in the news in terms of ableism, and
Yes.
kind of discussing like how, again, a lot of the things that we take for granted, right?
Mhm.
We see somebody who's in a wheelchair and we make assumptions about how they live and what they can do, what they can't do. And I just don't see it that way. I see them as, okay, they have a wheelchair. It's an extension of who they are, but they're still
Mhm.
completely independent. They're still completely functional. They can still do all the same things that, we can, just
Mhm.
slightly differently. So um I think the more I work as a PM&R doctor, the less I see disabilities as disabilities, the way that we
Mhm.
traditionally define it. And so I think that the rest of the world, though, still has to catch up to that. There's a lot of work to be done with
No
regards to
kidding.
that. Yeah, philosophy. Absolutely. Yeah.
And yeah, I feel like in my reading, have run into this concept that, in medicine in particular is kind of ableist with this
Hmm.
idea because, like, who are the people that practice medicine? There are people who, you know, I can't speak for all of medicine. We've all
Hmm.
had our challenges, as
Sure.
physicians, but many of us have had to function at a high level for a long period of time to complete, 4 years of medical training and a residency and, you know, college before that you've got, at least a decade of pretty high functioning um, stuff to
Hmm.
reach that area. And I think in medicine, very often we go to work regardless of circumstances, and so just that may give us a warped idea of um,
Hmm.
what's possible or
Yes.
what a different experience might be like.
Right. And I think that's why it's so important to have PM&R
Mhm.
physicians as part of your team or part of your network, because we can provide that kind of education. We can let you know when is it appropriate to consult us
Mhm.
as rehab specialists. What are the possibilities out there? There's so much now that we are able to do for people with disabilities,
Okay.
and also for our colleagues who might not feel comfortable, taking care of people with disabilities. There's actually I believe it was in the New York Times article that talked about how a lot of physicians are not comfortable, taking care of people with disabilities, because honestly, they just don't know. They just don't know how to.
Mhm.
And so a lot of it, I think, is based out of fear. But that's where rehab medicine comes in. We can help you. We can help you not be afraid. We can tell you, and educate our colleagues about what the possibilities are out there, whether it is assistive devices, DME technology. It's really progressing now. We're seeing a lot of use for AI
Mhm.
and robotics. So, it's a really great time to be in medicine and be a physiatrist. So we're
That's
here
awesome.
as allies,
Yeah.
for our colleagues. And I'm also here to say, like, don't be afraid. We're here
Yeah.
for help to help. Yeah.
And so as a pain doctor, or even if I were, say, a primary care, I mean, we can make a referral for physiatry,
Hmm.
physical medicine
Yes.
evaluation.
Right.
Even
Hmm.
if there is overlap, but there's a specific perspective that we might want to get in regards to
Absolutely.
the patient. Yeah.
Yes, yeah, I think you bring up a great point because where I see my physiatry background playing into pain management is when I
Mhm.
do go into those questions about function. Like, how are you functioning every day?
Mhm.
Like, what kind of difficulties are you having with your mobility? What
Mhm.
what kind of equipment do you have in your house? Is your home even accessible and safe
Mhm.
for you? As we know, like with a lot of pain patients, their function absolutely gets impaired when they're dealing
Yes.
with chronic pain.
Yeah.
And we also find that they have a lot more difficulty moving around. And the argument that I hear from my patients, and I'm sure you hear this all the time, is like,
Mhm.
wait, you expect me to exercise? I'm in so much pain. Like, what, are you
Yeah.
crazy? Like, I can't move?
Do you expect them to
So
exercise?
yeah, I do. I do, and I go through that again from a physiatry lens, right? I talk
Yes.
about the importance of, going to physical therapy and occupational therapy,
Mhm.
if only to, just help them get moving again and with guidance and with safety
Yes.
precautions in mind. But what I love about what my colleagues in therapy do is that they can also provide advice in terms of assistive devices that they might need, or help with a home
Mhm.
safety evaluation where they can take a look at your house and say, okay, well, you're going to need grab bars, because you're having difficulty with transferring,
Yes.
or getting up from a chair, or going to the bathroom, or taking a shower. So,
Mhm.
we have that extra lens that we see our patients through. And so I think it's great, when I'm able to talk about that kind of stuff with patients. It's not just them coming in asking for their refill and and
Yeah,
and
yeah,
that's it.
yeah. Well, and
Yeah.
and here's a yeah, kind of a question along those lines. So, not this week, but recently, I from time to time I'll see a person who has significant pain, and usually this is someone who's fairly elderly, and you have them
Mm,
go to stand from a chair, and they can't get up, or they have to rock,
yeah,
and this is a predictor of bad outcomes, right? Like if you
absolutely.
can't get up from a chair just on your own power, um, that is, it predicts a number of things. You can tell us exactly what, but I tend to refer that person to physical therapy, if
Hmm.
I see that. But is there more that we should do? Should we think about a physiatry evaluation
Yes.
as well if someone is
Hmm.
at that level of
Yeah.
ability challenge?
Absolutely. And, I think the physiatrist can help bolster, the physical therapy, occupational therapy
Yes.
exercises, or, treatment plan that the therapists come up with. So, when we do our exam, we are the experts in addition to our neurology colleagues and MSK colleagues as well.
Mhm.
It's a combination of both, so we can take a look at how somebody's strength, balance, coordination might affect their function. So we add that functional component, to our exams, and we can see where they're going to be having trouble. So if they're, for example, they're having a hard time or getting up, we're already seeing, yeah, that is a predictor for falls.
Mhm.
And their risk goes up because of that. So then, if that's the case, then what else can we provide for them? Let's say in the home, or even just with their own personal strategies, right?
Mhm.
To help them not fall. Whether they're at home or outside. I think the other thing that you sort of mentioned is that we're seeing this a lot in our elderly. And
Mhm.
one thing that I have not perfected, I do not have a great answer for this, but just having that conversation with somebody who's older, who's been so independent, and sort of identifying, oh, wait a second, you're at risk for falls because you aren't able to do X, Y, and Z. And then they take a look at you and like, I'm fine.
Oh,
Yeah, I'm fine. I have no problems. I've been doing this for many years.
yeah.
I'm okay at home. I mean, that is
Everything's
a
the same.
really, everything's the same. I'm not planning to do anything different. I think that's a really challenging conversation to have. But
Yeah.
when we as physiatrists talk to them and we start pointing out, well, um, okay, so if you're having trouble just getting up from a chair, how are you
Mhm.
functioning in the bathroom? How are
Yeah.
you getting yourself
How do
dressed?
you get off the
So
toilet?
exactly, right, and are you able to stand for long periods of times? And then they start thinking about it, and then they kind of get that look in their face like, "Oh man, somebody caught me." And it's
Right.
the, again, it's a really challenging conversation to have, but we have that ability to reframe things for our patients and to see it, to show them that we see it in a slightly different way. And so we can mitigate
Yeah.
those risks and de-riskify their personal risk as well as their
Mhm.
environmental risk. Yeah.
Very good.
So,
I have a thought too. I spoke with a patient just in this last week who, as we were talking about physical therapy and a referral for physical therapy, and this was someone who had some serious radiculopathy, had had an
mm,
injection because he didn't think he could tolerate physical therapy. And he's working and he's, mostly doing all the right things except for he hasn't been to therapy yet. And he asked me from like a place of genuine curiosity, how is physical therapy even going to help me? And in my mind, I'm like, well, I don't know. You're just going to build some strength. And I think you would have a better answer to it. What would you
yeah.
say to that patient who says, how is that even going to help me? How does that even work? That
Right. So I think, with when I tell my patients to just give it a try, usually it's the
Mhm.
let's try like a few sessions. If you absolutely hate it, that's fine. I
Okay.
can understand because I can't make somebody do something that they don't want to do,
Right.
for as long as they're cognitively intact, right? But I think one of the things that I point out is again that safety component. You have somebody who is specialized in musculoskeletal health and in exercise programs that can help uh, promote or support your whatever functional deficits you might have. So safety
Mhm.
and guidance are the first two things. The other thing I talk about, and I've used, therapists are great in terms of utilizing modalities. So that could be
Okay.
like ultrasound, heat, ice packs,
Mhm.
even other like manual modalities as well, similar to osteopathic medicine in some respects, where they can use that during their treatment sessions and help with their pain. So there's different things that they can offer as well. And then they can also, again, provide those recommendations I mentioned, to look at their functional capacity and see if there's anything that they might be missing at home to make them safer. So, and then as far as the actual physiological effects, we know, the positive effects of exercise,
Yes.
just in general, and also they can train individuals with balance and coordination issues, to help them with strategies, to address
Mhm.
that. I see it especially in our Parkinson's, population as
Mhm.
well, and our stroke patients. So, it's important to be able to address those things with the guidance of a specialist. So I think there's a lot more too that they can offer in terms of home exercise programs and again strategies to address whatever issues that they might have. So I always
Mhm.
try to tell them like, why don't you just give it a shot, and see what they can offer. And then usually, depending on what their diagnosis is, I'll put on my note, what I want them to address. So whether it's
Yes.
specific exercise programs or balance and
Yes.
coordination, programs, core
Certain
strengthening
specific.
exercises. Yep.
Yes.
Or let's say if it's OT, really focusing on your ADLs and IADLs. Yeah.
Sure. Or yeah, if I
Hmm.
think about this patient or one similar, well, doc, I'm having trouble getting in and out of my car. That might be something that
Mm,
I hear from somebody who has, back pain or hip pain,
hmm.
whatever the cause. I'm having trouble getting out in and out of the car. Oh, well, let's, send you to PT for, to look at this functional deficit. Well, no, it's just the pain, right? And I think there's, right, the patient's perspective is, well, if we just like removed this pain, like you can just pluck it out,
something magical,
then I could move. And there may be some truth to that, but I think there's this other twist to it but if you can correct certain functional things, certain aspects of movement, that you're going to get a different result and get to the same place.
Yes, I think that's I see that a lot too in my practice, where they're like, well, you just need to treat my pain and then I can move, and they're so very convinced that that's the only thing that will help them get better. And so that's part of the reason why, I bring some of my background into the way I treat patients. And I say to them, well, that's not, I can't take away your pain 100%. I mean, I'd be lucky if I did. So that's something that I always remind them. I'm like, I'm not a magician. I have to work with what I have, and what I have is your body. And your body right now is telling me that, you can only do a certain things or certain movements. Right. So I said, I can probably get your pain down to here. Right. But then I say, but you have to do part of the work too. So then it becomes a partnership.
To get it to here, or you mean the lowest it can go?
To lower. Yeah. And I said, I may not be able to get it all the way down, but if I can get you to here, now you got to do your part so you can get down to here. Right. So, and I said that, we can have different strategies to address those things. So that's when I talk about, let's say we've already talked about the medications that they could potentially be on, because, a lot of the time that's part of why they're seeing you. They want a medication to help take away the pain. Like, you got the magic wand, and I say, this is not magic. Right. And so I try to kind of bring them back down to earth a little bit, and try to reframe those expectations.
Or I say, like, okay, the medications, they're not that good. They're actually, they're okay.
Right. Exactly. And a lot of this is also, again, like mindfulness. It's, I talk about meditation. I talk about exercise. I talk about nutrition. So I do have a master's in nutrition.
Wow.
And so I talk about like an anti-inflammatory diet. I think that it's great to use food as medicine. And I think we're really seeing a huge movement towards that. And then I bring, the alternative adjuncts to pain management. So that could be acupuncture, that could be Reiki, that could be Tai Chi. And then I also talk about osteopathic manipulative treatment or medicine. So then I offer all of these, to my patient. I say, look, if you haven't been addressing your pain in this kind of holistic, very comprehensive and thorough way, we're not doing everything that we can. So I try to remind them that there's always going to be something else and something more that we can do. And like a lot of the, if they're seeing me for the first time, and maybe they haven't heard anybody else talk about what I talk about, it sort of opens their eyes, and we almost start from scratch, again. And it's kind of nice to have that that ability to help them in other ways. It's not just okay, you're here for medicine, but that's not all that I'm gonna do for you. We have to try everything first. And try to make it as natural as possible for them. Because I'm also seeing a lot of patients, prefer some of the more alternative options. So it's
absolutely.
Nice.
I have patients that won't hardly take a medication.
And,
that's okay. That's okay. That's a choice you can make.
Right. But it's also it's interesting because it's always a balance. You get those who only want the medication, and then the ones who don't want the medication. And we've done everything very conservatively, and it works to a certain degree. And then you're like, maybe we should revisit that medication. So you're having almost two very different conversations with two different sets of people who have very different philosophies. So it's never a dull moment, certainly, in pain management.
And like, you're meeting people where they are, right? If people come with a set of beliefs and a certain amount of knowledge and their experience,
right,
that informs kind of all of this. Yeah, and I think it definitely informs how you are going to communicate with that person and how you're going to be able to connect on the best therapies for them, and really informs those beliefs that they start with.
Yes, exactly. Exactly.
I like this. I'm going to put your quote here in the chat here, that these adjuncts, Reiki, Tai Chi, acupuncture, and inflammatory diet, we're not doing all we can. I like it. I like
Right.
it.
Right.
Yeah, I think that's so important. I had somebody that I saw really recently who sometimes when I have a complex patient, I might, or at a first visit in particular, if it's not clear to me, what is the patient's the most interested in, or exactly how we can help them, I will ask, what are you hoping that we can do for you? And the patient today said, I want you to make it all go away.
Ooh,
Yeah,
that's tough.
that was heavy.
Yeah.
It was heavy.
Yeah, it is
Yeah.
heavy. So, I've often found myself as a pain management doc talking about psych a lot.
Mhm.
Like, I feel like 50% of what I do is psych, and even in rehab, because there's a lot of motivational interviewing in
Mhm.
rehabilitation. So just taking somebody who's had a stroke or a spinal cord injury and they're fresh injuries, and they're looking at you like, why are you expecting me to do rehab? Like, I can't move.
Yeah, yeah, that's a
It's
hard
the
conversation.
Yeah.
Like, are
Oh,
you
it's
ready to hear that if you're the patient? Yeah.
right. Yeah, it's super hard. And, having to sort of do a very similar conversation to somebody in pain management, they're like, "Oh, I just want this all to go
I
away." And
can't
I
do this. Yeah, just yeah.
right. And
It's
so
not
I
easy.
try to ask them, "Well, what exactly do you mean by make it go away? Is it just the pain?" And then I try to go through, "Okay, well, what are your triggers? What makes you, feel
Mm,
pain?" Are there other triggers that are non-physical that cause you your pain?
mhm,
So I
mhm.
go down that rabbit hole, and it is a rabbit hole for sure, because then they start, talking about a lot of other things that you might not expect, and it's a lot of it is psychological, and that's why if part of your pain management team should not just include a physiatrist, but a very good psychologist, a pain psychologist, to be able to identify and sort of tease out those triggers that are not really physical,
Mm,
in nature.
mhm. And what do you
So,
mean by triggers? Like,
well, if somebody, so for example, I had a patient just recently, actually. She admitted to me that she has a lot of depression. She suffered from depression for many,
mhm,
many years. She's been on medication for a long time. And this was she's kind of going through a transition, because the
mhm,
role that I play in the clinical practice in Wisconsin, where I'm a locums doc, is
mhm.
I'm sort of a safety net for the patients who were under the panel of a physician that just recently retired.
Okay.
So basically, I am a new person to her. She has no clue,
Mhm,
who I
mhm.
am. She doesn't know what I do. And she comes into the clinic with this conversation. It's my first patient also of the day. So she comes in, and it's very heavy, because then she talks about how, like, there are certain days when she just can't get up,
Mhm.
and she has a teenage son who's about to graduate and go off to college, and she can't do anything, and she wants to be there for her family and for her son, and for her husband, who, ironically enough, too, takes the same medications as she does for pain, and is
Mm,
also a patient in our clinic.
okay.
Yet he experiences pain completely differently.
Hmm,
Yes, and he's able to take maybe, one, Percocet, and is fine the entire
mhm.
day. One Percocet for her touches nothing, so, then we kind of, she also admits, she feels that her, certain, moments in her life where she feels that the depression is really a trigger for her pain. Like, if
Okay.
she's feeling particularly sad, or feeling particularly down, she notices that she is in more pain and is
Mhm,
wanting or requiring to take more pain
mm,
medication.
mhm.
So then we kind of go into that, so that's what I mean when I say triggers,
Yeah.
like, okay, when you
Trigger for a pain
say,
flare. Yeah, trigger for me.
right, is this, what are you feeling depressed about?
Mhm.
Like, and then she starts talking about like how she doesn't feel she's performing well as a mother or as a wife. And I was like,
Mm.
okay, this is going to be that conversation. And,
Yeah,
as a physician, you have to kind of prepare yourself too, because um, these are all really very heavy topics, and
yeah,
you're going into people's lives, and they're,
yeah,
sharing very intimate details of their lives, and you have to be prepared to address that in one way or another. So one
yeah.
thing that I say to her is I said, okay, data is your best friend. All
Mm.
right.
Mhm.
Yeah. So I'm a writer by
Mhm.
nature. And so I tell my patients that I need to have them keep a journal for me. Data is your best friend. I need
Mhm.
to be able to help you. I need to know when you're having, your pain flares, what
Mhm.
is causing them, what is happening in that moment. And how is your, and again, going through those same, sort of adjunctive treatments that I go through, like, what's
Mhm.
your diet like? Are you moving? Are you exercising? What is
Mhm.
currently happening in your relationship, or what's currently happening at your job? Like, what were you doing that day? Were you doing more strenuous activity? So I said, I told her, I said, you need to keep a diary for me, and the next time that you come, we're going to go through this diary and really tease out if your pain is truly something physical that you're going through, or something that's maybe more psychological, and maybe
Mhm.
more because of the depression and anxiety that you've been experiencing all these years.
Mhm.
So, and she kind of looked at me like, "Oh, you want me to keep a journal?" I said, "Yes." You
Mhm.
have to show this to me, because I right now, from our conversation, I can't tell what's really your trigger.
Mhm.
This is my first time meeting you,
Yeah.
and we only have like 30 minutes, right, to go through this.
Mhm.
And so I need more data to be able to truly help.
Right.
Yeah.
Yeah, and I think that's so important. And 30 minutes is pretty good really to have some time
Yeah.
to dive into all that. And
Right.
then to have
Hmm.
the person come back with some data about
Hmm.
their diet, what's happening at home, and to be able to dig deeper into that.
Right. Yeah.
Um, and you mentioned something about, pain having psychological components of it. Is this to say that pain is made up or in someone's head? I
No.
don't think that's what you're saying, but
No,
let's
not at
just
all.
clarify that because I do think it's
Yes.
it's such a nuanced thing to be able to clarify, right? Like
Mhm.
pain is
Mhm.
real that
It is.
patients
Yeah.
report.
Mhm.
Um, but there are also factors that can be modulated or helped that impact it, right? And that's kind of what you're talking about is developing
Right.
a journal to track these things. I think that's really yeah, I think that's really a nice practice.
Well, I think also, like, keeping a diary sort of
Mhm.
removes them from that, event of pain, if that makes sense.
Mhm.
Where they can kind of take a step back and,
Yeah.
not be in that moment, sort of like
Yeah.
mulling over. I think the part that I mean by psychological as well is, they might say, okay, I identify, I'm having pain right now. And then that's kind of it's like a mouse on a wheel, where that's all they're thinking about,
Mhm.
and it does psychologically affect how you function, because if that's all you're thinking about, then absolutely you're not going to be able to function. You are going to want to stay in bed. I mean, certainly it's happened to me, as
Mhm.
well. And I think we've all had those moments where especially during COVID as well, it
Yeah.
was not helpful for pain patients
It
at
was not
all.
helpful, yeah.
It was not, so, and I think
Yeah.
that really fed into a lot of the pain that my patients at that time were going through.
Mhm.
So, again, teasing that out is super hard. But
Mhm.
I think keeping a diary allows them to objectively review what was going on in that
Mhm.
moment that they were having a flare, and being
Yeah.
able to identify, oh, yeah, I was working in the garden the other day. I probably overdid it. And so it allows them to be able to find those reasons that are tangible. It's not just
Mhm.
this thought process that they're going through. It's like something
Right.
like, oh, okay, I know I did X and it caused Y and Z. So how do I help
Mhm.
myself not go
Yeah.
through this process again? So
Yeah, and it might
yeah.
almost give them more confidence to deal with it. And frankly,
Hmm.
that's like kind of yeah, in a case like that where you might find a physical trigger, right? Like it's kind of helping determine, what are those physical factors that are impacting
Hmm.
pain, right? Um,
Right.
but I do
Right.
think that the connection of like mood and pain is so important. And, you know, like here's depression and here's pain and they're bad for each other, basically.
Right.
They're
They're
just
they're two peas in the same pod. They
yeah, they
love
are.
to
They're
talk to
like
each
they're like
other.
an
Yeah.
adversarial relationship, they're
Right.
they're
Exactly.
closely linked and bad for each other. So,
Hmm. Hmm.
I think to help patients realize that and that's a real thing and it's not a it's just very well described in the literature as we
Hmm.
know, um,
Hmm.
and really treating it's important to treat the mental health aspect um, of people's pain in addition to just treating the pain score.
Right.
Also,
Right.
those other pieces.
Yes. Yeah.
Yeah, thank you. So if you were giving a patient, what would be some of your top tips to stay healthy? If you were going to talk to a person, what would you say?
Just to stay healthy or to stay
Yeah.
pain free? Just to stay healthy?
Well,
Well,
maybe both. Yeah.
okay, yeah. So, I mean, I think I utilize a lot of the things I've already mentioned. It's a very comprehensive and sort of
Mhm.
holistic, whole person approach. So,
Yes.
when I talk about, staying healthy, I'm a foodie. So,
Mm.
I mentioned to you earlier, I gained quite a bit of weight when I was during COVID. So,
Mhm.
I'm even finding myself like following my own advice,
Yeah, you're
which
on
is
a journey
very
too.
rare. Yeah. When do doctors follow their own advice, right?
Right.
So
Yeah.
maybe that's a different conversation for another day. But
Yeah.
um, even if I use myself as an example, so the first thing is nutrition, and I did, finally, change. I like towards the middle of last year when I started feeling pain. Actually, I
Mm.
said, "Oh, I understand now what they talk about when you've gained weight and you start feeling pain and everything feels stiff." And I'm
Mhm.
like, "I am too young for this. I got to change my diet."
Yeah.
And I
Yeah.
did, and amazingly enough, I did start following an anti-inflammatory diet,
Mhm.
and it helped. So the first thing I say is, are you using food as medicine? Are you putting the right things in your body? I love
Mhm.
talking about what I learned in nutrition school. It's sort of using the colors of the rainbow to guide
Mhm.
your daily habits. So I
Mhm.
tell my patients, are you picking a fruit or a vegetable? Five different colors, right? And are you picking a fruit or vegetable from each color?
Mm.
And that helps, with your if you have any weight loss goals, but also for improving your inflammation and
Mhm.
getting fiber. So it's sort of a three-pronged approach to improving your nutrition. So I talk about food as medicine, and I remind myself of that. Secondly, am I moving? When I look at how we are in medicine, a lot of us spend a lot of time sitting down and writing notes.
Yes.
That's Notes are the bane of my existence. Like if I
Mm.
can have someone else kind of scribe for me, the better. Because then, I'm sitting all the time. So
Yeah.
what did I do? I went and bought myself a standing desk, and in the clinic, I asked for a standing desk.
Mhm.
I also have a treadmill underneath my desk now.
Oh, there you
So
go.
even if I'm moving super slow, I'm still moving,
Yeah, something.
Um, right. And everything that we do matters, So like a lot of patients, they tell me, "Oh, I exercise at work." That's great, but if you were really looking at weight loss, that's not going to be enough because our bodies adjust to how we move at work. So, the way that we metabolize, right? Like it basically readjusts based on how much you're eating and how much you're moving. So, if you're
Okay.
really thinking about weight loss, you got to do more. So, or some people say, well, I get my exercise through chores in the house.
Mhm.
Okay, so that's fine. So why
That's
don't we
easy.
do like a
Mhm.
little exercise program? Like if you're washing dishes and you're standing up, why don't you, try to get on your tippy toes, and sort of work your your calf muscles,
Mm-hmm.
while
Mm-hmm.
you're doing laundry or doing, the dishes. So small things like that. The third thing, and probably the most important, is mindfulness. Am I
Mm-hmm.
addressing my self-care needs? And so
Mm-hmm.
one of the things I've learned through our EBS,
Mm-hmm.
community and Commonwealth, is creating a calendar, to sort of block time for
Mm-hmm.
yourself. So every morning I now have time, like my me time, where I do journal, I sit down and meditate, and I set my intentions for the day.
Mm-hmm.
Um, and I've found that having, done that in the last year or so, not quite a year, but since I
Yeah.
joined EB, but that's been super helpful in terms of, um, you know, getting myself ready for the day, and sort of ready to conquer the day,
Yeah.
no matter what difficulties there might be. And also part of the journaling aspect is my journal is a journal of gratitude. So when
Mm-hmm.
I wake up, the first thing I ask myself is, what am I grateful for today?
Yes.
And it could be one thing, it could be two things, it could be three things. Before I started, I think because I was sort of in the depths of COVID depression, as I like to
Mm-hmm.
label it, it was
Mm-hmm.
really hard. It was really
Yeah.
hard for me.
It
And
gets
then
easier.
yeah, I started
Yeah.
doing it, and then I said, "Oh, I'm still writing." And it was kind of a nice surprise.
Yeah.
But yeah, it's I think that's really important. Making sure that I have both, my nutrition, my physical movement, and my mind, all
Mm-hmm.
in sync. And it's very actually osteopathic, because
Mm-hmm.
that's what we do. We connect our
Yes.
body, mind, and spirit. That's our approach to things. So I
Yes.
am, not just preaching my education, but I'm living it, which is really important, because when I do talk to my patients, I find that I'm able to connect with them more, because I'm also
Sure.
going through, my own
Yeah.
journey.
That's right. Yeah, and I
So
think we
yeah.
all are, right? Like
Hmm.
we're all aging. Is what I've
Right.
started to say.
Don't remind me.
I know. It's like,
I found my first gray hair last year, and I
mm,
was like, I
mhm.
freaked out. I
Yeah,
said, "Oh no, not yet."
we're all aging. But
Yes, yeah.
yeah, I think that's great, and the importance of moving and staying active is big, and yeah, probably just really only gets bigger. Um,
Hmm.
Oh, and I did want to say one thing about the gratitude journal. I think I have seen some data that the gratitude journal can be as effective as an antidepressant. That
Hmm.
actually, like a regular practice of gratitude journaling over months, has a similar effect to a SSRI. I mean, it's
Right.
real. It's real
Hmm.
medicine to um, really harvest those grateful thoughts and meditate on them, use them, and improve
Right.
that way.
Yeah, and sometimes if it's not, journaling, and let's say, I don't feel like writing that day,
Mhm.
I think I still make it a point to look at myself in the mirror and go through that practice, even if I'm not writing it down. I think saying it
Mm.
out loud is
Yes.
also just as important,
Yes. Good for
It
you.
doesn't have to just be in black and white, but
Mhm.
it's something that you can also hear yourself saying.
That's
So it makes
nice.
it, a little bit more real too. Hmm.
Sure, sure. Yeah, I'm sure for some people that could be particularly impactful in the mirror. That's awesome.
Hmm.
Well, Dr. Tamayo, you are just a treasure trove of great stuff, and I've really enjoyed talking to you. Um,
Thank
so I just will kind of help us wrap up. I appreciate your tips for staying healthy and for staying pain free. And we've got the link in the comments here of where people can find you currently on LinkedIn. And stay tuned, more things to come. We can comment later once we have more links for you.
Yes. Thank you so much. This was
Excellent.
great.
Yeah, great to be with you. Thanks for being here. All right, and for those of you watching, we would love to serve you at Lifestream Health Center in Bowie, Maryland. We're available for new patient consultations and making acute and chronic pain management caring, accessible, patient-centric, and evidence-based. Come see us. You can find us online at lifestreamhealth.com.